Okay. Okay. Welcome, everyone. Like a few more people traveling through cyberspace here. All right, let's get started. Good afternoon, everyone. I am Jamie Strauss-Clark. I am the facilitator for the Crisis Response Improvement Strategy Committee, and that is our meeting today. This is meeting number 12. So welcome. We've got, as always, a very action-packed agenda. Before we dive in, I just want to, as always, orient everyone to the tools we're going to be using to communicate with each other in this digital space. I'll start by introducing Catherine, who is on the screen offering ASL interpretation. She'll be trading off with Jackie, who's currently off screen but will be coming on in 15 minutes, and they'll be switching back and forth. So if you need ASL interpreter support, you can pin them on your screens and you'll be able to see them and get that support throughout the meeting today. You could advance the screen, please. All right, so as a reminder, I have 2 slides here to show you how we use the Zoom tool. The first slide is intended for CRIS committee members, and then the second one is going to look a lot like this one, but it's meant for our community members and guests today. So I'll start with the CRIS committee member slide. As a reminder, if you could please keep your mic on mute, and Brittany will highlight that. Yep, that's the mute button over in the lower left-hand corner, unless you're speaking, of course, and that'll just ensure we avoid talking over each other. If you're a CRIS committee member and it's available to you, we would really appreciate it if you could keep your video camera on, particularly during the portion of our meeting today where we are having group discussion. That just makes it easier and more collaborative as we facilitate. If you could advance the button again, please. We use the raise your hand function to let me know if you want to offer a comment or ask a question or otherwise engage in the conversation. You click on that reactions button in the lower right-hand corner, it pops up a little screen, and then click on raise your hand and I will call on you. I believe you hit *6 from your phone if you would like to, if you're participating today by phone. And of course, you can wave your hands at me and I will try to catch that and call on you in the order in which I see you. Also, as a reminder, we do use, for CRIS committee members, we can use the chat function. If you would prefer to share a comment or feedback in the chat, you can send it directly to me, Jamie Strauss-Clark. This is for CRIS committee members, and I will relay the comment. Please let me know at the beginning of your comment or question if you would prefer to keep it anonymous, and I will just say that this is a chat from a CRIS committee member or a comment from a CRIS committee member. Otherwise, I will attribute the comment or question to you. And then finally, if you could click ahead one more time. Finally, if you'd like to see as many CRIS committee members as possible on the screen when we don't have slides up, you can click on that speaker view and change it to gallery view. And that way you'll see more people. All right, let's move on to the community and guest slide. If you could click ahead. So similarly, I'm going to ask everyone observing today as a guest or community member to keep your mic on mute for the duration of the meeting, or at least until we get to public comment if you are signed up to make a comment. I'm going to ask community members to keep your video cameras off. Again, because we have so many people participating, it does really help me to distinguish between community members who are observing and our CRIS committee members. So if you could keep your cameras off unless you're making a comment at the end of the meeting, that would be great. Advance the button. Again, keep speaking. You can put speaker review on gallery view and see more CRIS committee members. That's that top right button. And I think that's it for the etiquette. So if we could advance the slide. Actually, let's shut down the slides for a moment because Anna Nepomuceno from our CRIS committee is going to offer some words of welcome today. Anna.
Good afternoon, everyone. My name is Anna Nepomuceno, and I'm the Public Policy Director for NAMI Washington. Thanks for joining us today at the CRIS CRIS committee meeting. Today, we'll be tackling another topic that is complex and urgent, the unique needs of youth in crisis and how we better address those needs in a just and compassionate way. According to the Harborview Injury Prevention and Research Center, an average of 2.6 young people between the ages of 10 to 24 die by suicide each week in Washington state. Despite these statistics, over half of Washingtonians between the age of 12 to 17 who have depression have reported that they don't receive the care they need. We all know that more and more young people are experiencing mental health challenges due to the pandemic, economic uncertainty, and the current state of our country. Our youth are suffering, and our state needs a behavioral health crisis system that could respond to them in a compassionate, therapeutic, and equitable manner when they dial 988. Today, we'll be looking at the gaps in our current youth crisis system and discussing how to address those gaps. We appreciate the engagement of community members and professionals, and most especially people with lived experience. At the March meeting, we had a candid and thoughtful discussion. Even though we came to the table with different perspectives and experiences, we shared a common goal of improving the crisis system. And this is helping us listen to each other, find common ground where possible, and respectfully acknowledge the places where our perspectives diverge. Let's come together again to help our young people. Let's put our hearts and our minds together to find compassionate solutions that address the needs of youth from every community, especially those from BIPOC, LGBTQ, rural, and other marginalized communities. Thank you.
Anna, thank you so much for those words of welcome that are so directly tied to what we're going to be talking about today. I really appreciate it. Next, we have a special treat today. We have Catherine Akia. She is a consultant working with the American Indian Health Commission, and among other projects, she supports tribes in planning to expand crisis response services and the Tribal Behavioral Health Advisory Board in strengthening a tribal-centric behavioral health system. She's going to share some of the outcomes of this work with you today. So if we could cue up those slides and hand it over to Catherine. Catherine, thank you so much for being with us today and sharing some of this information.
Thank you for having me. Chakbashwai, Inknashwaniksha Catherine Akia. Good afternoon, everyone. My name is Catherine Akia, and as Jamie was introducing, I'm with the American Indian Health Commission. Oops. I see a personal story slide.
Yeah, that's not quite right. Let's there. Sorry, we're giving you a little spoiler here.
That's okay.
If those slides aren't in there, I think I have them. I can put them up, but bear with me.
I can put them up too. We're gonna give everybody kind of a quick overview of some of the things happening in the what we kind of loosely term the tribal behavioral health system. Which
All
is
right, Catherine, give me just a second. I can
all sorts of, oh yeah, no problem.
Sorry about that. We have a lot of content today, so I think it might have just gotten lost in the shuffle. There we go. Right. I'm going to count on all of you to let me know if I'm in the right presentation mode here.
Hey, that looks good.
Okay, you just tell me when you want me to advance it.
Okay, no problem, no problem. Thank you. Thank you so much. Yeah, good to be here. Yeah, go ahead and do the next slide. So whenever we're talking about Indigenous people and tribes, tribal nations across the state, across the Northwest, one of the things that we always do in all of our presentations is we start out with this, and this is really to acknowledge the impact of what it was like to lose this much land and to be moved around. If you go next slide. You can see the difference of what it was like to what we have now and what we have here in the Northwest. Next slide. Then I always preface our presentations with that, just because I kind of want to ground folks in the reality of what it's like to experience the high levels of mental health, of substance use crises, and how we're looking at it as we go about this work. So this here is a map of the different tribes in Washington, as well as the ones that have tribal health clinics. And so just to give you an idea of the behavioral health services out there. A number of tribes have what you would consider, counselors. There are opioid treatment programs. There are some different facilities. There are different outpatient programs that are available, some different crisis response, different levels of crisis response that are happening, some informal, right? What we call like the anti-network, somebody in recovery or somebody who's known in the community who's there, the go-to person. And then some of the tribes also are working on some more formal models of implementing crisis response services. And next slide. And with just a few minutes today, I don't have time to run everybody through kind of the fundamentals of the public health law and the authority and all that, but I really want to come back to this one key thing that we really focus on when we're talking about tribal services and what falls under this umbrella of what we call Indian healthcare providers, which is this umbrella term for both the tribal clinics, the Indian health services, and the urban programs. And that is that they really have a dual role, that their dual role is both as providers of health services, so peers within this behavioral health system and colleagues, and entities within a governmental authority. And what you see when we start looking at our projects that we've been working on, why this part is so important, because so many of our projects have both a practical implementation side of things and a government to government relationship. And so we work quite a bit with different agencies within the state of Washington as well to be able to recognize the systems so that tribes and urban programs are able to expand their services and respond to crises in the community. Next slide. Okay, so here's the slide with all the pieces on it. I just want to go and highlight a few of them and to give you kind of an idea of things that different entities have been working on across the state and across the different tribal nations. So one of the things that most aligns with this work with the CRIS Committee has been the Tribal-Centric Behavioral Health Advisory Board's work, both in their capacity as advisory board and in their capacity over the last year and some as the Tribal 988 Subcommittee. And through that work, they have both in the past looked at evaluation and treatment facilities and most recently looked at some of the different projects as they were related to House Bill 1477 last year. So some of the big assessments, giving feedback on different models that were being used, and now currently working with Healthcare Authority and others on giving feedback on mobile crisis teams. So that's kind of where we are in that. That entity or that group meets once a month and has a variety of representatives on it from different behavioral health programs, from different organizations that cross into behavioral health. And so that's the group that in the future will also be giving some additional guidance on some mobile crisis feedback, much like I think was the last meeting or maybe 2 meetings ago when Matthew Gower was here and he was presenting about the dispatch protocols and that we're doing the same thing, but through the Tribal-Centric Behavioral Health Advisory Board, giving some feedback through there. And then also I wanted to highlight the 2020 Washington Indian Behavioral Health Act. So that was put through a couple of years ago. It really opened some doors, recognized some of the things, for example, tribal designated crisis, the ability to have tribal designated crisis responders, to have the state crisis responders, notifying tribes about people if there were assessments done. One of the, we have some of the same issues that I hear again and again in these meetings and other meetings and kind of losing people in the system. And so these are some of the changes in the works that we have done to do that. And I put on here and 2024 updates because we couldn't get our legislation off the ground this year. We had a bunch of changes that we compiled over the last year, things that need to be updated and changed in the RCWs. And it didn't get going this year, but we'll come back again this next year with more. The other thing that we do, there's quite a few trainings that go on. So when we talk about trainings, kind of like the previous slide I just mentioned, we talk about giving people an understanding of tribal sovereignty, of how tribes interact, of the federal trust responsibility, the need to provide health and healthcare, and the need and how those systems coordinate. And we do this 101 training. And so what we're doing right now is we're working on, we have trained a number of people in the crisis response system, everything from forensic navigators to designated crisis responders, accountable communities of health, providers, Office of Behavioral Health Advocacy. So kind of a whole different range of people who are interacting with the system and really trying to come back to some of those fundamentals of understanding what tribal clinics are doing and who they're interacting with. If they're interacting with somebody, if we want them to make sure that they're able to provide culturally appropriate services or make recommendations for culturally appropriate treatment. So we've been doing those trainings, and going forward, we're actually working on getting some of those into an online system so they could be a go at your own pace, take some of the 101 classes. Along with that, to support the other things that are happening in the tribal behavioral health crisis response world, the development of code templates. So codes are tribal laws. So for the tribes who do want to expand some of their services, they might be updating their laws to recognize that. The other two things are the Behavioral Health Hub with a new name coming soon. They're working on rebranding and getting that message out there. But that is a resource for providers and families at tribes or urban programs who are interested in knowing more about the behavioral health resources out there and things like finding beds or getting connected with their local resources. And of course, the Native and Strong Lifeline, which is the new dial option 4 from 988, which is very exciting and always has great exciting updates about how they're doing. And then also other plannings that we've been doing, tribal DCR planning meetings. I kind of lump that under a big umbrella. There's several tribes who are looking at having tribal designated crisis responders or expanding tribal designated crisis responder capacity in some way. And so we've done quite a few planning meetings with those tribes, as well as then shared those resources with other tribes that are interested in that, because that same conversation then leads to the next point there, tribal behavioral health crisis response planning in general, which is really where a lot of our conversations have come up about the mobile crisis teams and the potential models out there. So I think one of the both challenges and unique aspects of the tribal crisis response system is that they're not in big urban centers, or most of them aren't. They're not going to be so well resourced that they can meet those big SAMHSA models, or they have the full 24/7 coverage. And so we've been working with several tribes about what does it look like to have a mobile crisis response that might be part-time, that might, in one case, we're looking at one tribe really wanted to cover 100% of the time, but realized maybe they could only respond 30% of the time, but they could track and coordinate 100% of the cases, right? So it's kind of looking at what they can do there. The other things that we're have assisted with in the past is updating DCR. So this is back to the state side now, state DCR protocols and Washington administrative codes for implementation so that they align with the law and how we want to see some best practices with working with tribes. There's been a ton of information gathering across all sorts of different professions, just like in the state system, the tribal system interacts with all the different departments and different branches of government. And so when we go into planning, we want to keep everybody involved and informed and use that information to provide the best whole person care that somebody can get. There's also been work with Healthcare Authority on sustainability planning, and development of a case rate and other potential projects, and getting some guidance on billing. And then soon to come this year will be 1134 and 5120 feedback on those WACs as they develop, because we want to make sure that the door stays open for the unique needs of tribes and how their programs might look a little different, but we'll still be serving both tribal members and residents of Washington. So that's everything in a nutshell. I was told to do a quick recap. So that's a bunch of different projects really quickly. Always please feel welcome to reach out to me. There's my email. I put it on there, or if anybody sends me a message or something, I'm always happy to respond.
I'll leave that up for just a second as I say a big thank you to Catherine for preparing this presentation and sharing it with us. As folks who've been at the last few meetings know, we've kind of been alternating between doing it's now traditional for us, land acknowledgement, and using this time to share information about the great work that tribes are doing to strengthen and enhance the crisis response system that's tribal centric. So Catherine, really appreciate you coming and sharing this information with us today. And folks, if there are other ideas that you have for how we can continue to educate ourselves on the work that tribes are doing on behavioral health, please do send me a chat and let us know, and we will do our best to try to bring that to our CRIS table. Catherine, thank you again so much for your time and the great information you shared.
Yeah, no, thank you.
And Brittany, if you could put the other slide deck back up with the objectives page, I'll just walk our CRIS committee through the plan, or Chloe, thanks Chloe for the plan today. So up a few slides. There we go. So objectives today, as always, we're going to, of course, ground ourselves in where we've been, where we are now, and where we're going in the CRIS process. We are going to spend a little time with our state agency leads to answer your questions that you might have had after reviewing the monthly CRIS e-newsletter that you received last week. And then we'll spend a little time getting a foundational understanding about the Healthcare Authority's youth-focused crisis response model. This is intended to inform CRIS discussion about youth crisis response later in our meeting today, as Anna mentioned to you in her words of welcome. And in addition to hearing from Healthcare Authority, we're also going to hear from Kashi Arora, a CRIS committee member with a special expertise in youth and youth crisis response. And then Kristen Wells and Bipasha Mukherjee from our Lived Experience Subcommittee are also going to share some insights from discussions that the Lived Experience Subcommittee have had on this topic. Then we'll aim to take a break around, let me give you a timeline so that you can prepare for that, a break around 4 p.m. And come back together and devote the remainder of the meeting to a group discussion regarding considerations around youth-focused crisis response, with the intent of eventually informing steering committee recommendations down the road. We'll confirm action items and next steps, and then we have 2 people signed up to make public comment at the end of the meeting today, with our plan to adjourn today at 5:30. So those are our objectives. But first, and well, actually, I do want to just mention one thing. Typically at this time in our meeting, we show you our work process or our decision process for CRIS committee and ground everyone in where we are and where we are going. We are still in a little bit of limbo. We're waiting on finalization primarily of the biennial budget. So we're not quite ready to show that updated decision process that I mentioned last month. So, but I do believe next month we'll be able to show it with more clarity. But do note that all of these discussions, the one we had last month, the previous months, and what we're doing today, and the adjacent work group discussions will lead up to policy recommendations that the steering committee will be making and informing the report that's due in January. So again, don't have a decision process, updated decision process slide to show you today, but I believe we'll have something worked out to share with you, and all the variables that are currently balls in the air we'll have worked out to share with you next month. Last thing I'm going to say about public comment, as I mentioned, there are 2 people signed up for public comment. I will be preserving time for those 2 folks to make comment at the end of the meeting. We do have a very jammed agenda, so we may run out of time for additional commenters if people sign up, but please do send me a chat if you'd like to be put on the list, and I will do my best to get to everyone today. And with that, I would like to turn it over to Bipasha Mukherjee to introduce our personal story today. So Bipasha.
That mute button. Okay. Namaste, everyone. My name is Bipasha, she, they pronouns. I serve on the CRIS and its steering committee as a person with lived experience. I also have been answering calls on the crisis line for over 25 years. I met Brittany Miles when we both joined the North Sounds Regional Crisis Response Community Advisory Group, which supports crisis de-escalation and a behavioral health specialist going out with first responders. Brittany was born and raised in New York and moved to the Pacific Northwest in the mid-90s for work. She stayed because apparently of our lifestyle and the people here. She's worked at Microsoft, Starbucks, and T-Mobile as a full-time employee and as a consultant in product development. She also serves on the CRIS's Technology Subcommittee. She's an opinion writer published in the Seattle Times, Publicola, and Seattle Child. She believes in politics as a method of changing the world, and she loves the simple pleasures of life, walks, taking care of her Chihuahua Teddy, movies, and talking. I'm grateful that Brittany is here to share her lived experience with us today. Here's Brittany.
Thank you, Bipasha. That was such a wonderful introduction. And thank you everyone for having me today. So I'd like to share my story with my daughter, who is 15 years old, and we have been hiding in plain sight. And if you could go to the next slide, please. So over the past 4 years, and you can advance the slide, I've been parenting my daughter, Jamie, which is a pseudonym, and she has early onset schizophrenia. We've lived in Kirkland and now Bothell, so we've been in 2 different school districts, and in Lake Washington School District, I had preliminary understandings that something potentially wasn't right. We had ADHD screenings, we had dyslexia screenings, and that was true, but still something wasn't right. There's been a lot of anxiety, a lot of dread. I've been going from place to place. I've been very fortunate in the fact that I made a good income in the tech industry, and I had pretty good insurance, especially when I was working at Microsoft, but we've been failed by the system, and in ways large and in some ways small. One of the biggest areas of trauma on my journey has been when I was falsely reported to CPS last year by an agency that works with DCYF. And if I didn't have the understanding of how social services worked because of my mother being a social worker in New York for over 30 years and having a father that was a doctor, I don't know what we would have done. We are an African-American family. And even though I lived in a really nice suburb, drove a really nice car, and had a really good job, the system still criminalized me. And even speaking this aloud again, it's still fresh for me, and it hurts. It just really hurts. These are the people that are supposed to help me, but couldn't help me or chose not to. And they chose to criminalize a time which was most vulnerable and still continues to be vulnerable for my family. Because of my work and income levels, there was no support at the local and state levels. I call it the gap. Because we are not at poverty level, and nor are we part of that 1%. Because we have middle class or upper middle class income and health insurance, one would believe that we could take care of ourselves, but not. We can't. I will tell you, medication, prescription drugs are not covered by most of these insurance companies. Now that my daughter has AppleCare, they won't cover her antipsychotics. And when I looked to fill them for 90 days on Amazon Pharmacy, it was over $800, which I no longer have access to. Even when I had insurance, like out of Microsoft, the pills that she would be prescribed would change in price every month. So I had to work with my ex-husband to figure out how we're going to pay for this, in addition to all the other things that weren't covered, like therapy, psychiatrists, testing. So it's really hard for people like us who are hiding in plain sight to have a life. My daughter, Jamie, wasn't well enough for school and still doesn't really attend school full time. She attends a virtual school. Consequently, as a single parent, I can't work. I mean, one of the slight benefits of the pandemic is that we got used to remote work, but still there is a need for me to be on site to collaborate with my peers. And consequently, I had to give all of that up because I needed to be home to take care of my child, because there's no place for her to go because she doesn't go to school every day. And now with the downturn in tech, it's been difficult for me to find a new job, and consequently, I've had to file for bankruptcy. So I've gone from an income being in excess over $200,000 a year to living on unemployment benefits, which pay me about $4,000 a month. And when they run out, I don't know where I will go. The next slide, please. So how we're doing today. Next slide, please. I like to say this to people because even though I shared a lot of negativity on the first slide or the reality of our life, still be fearless because there's hope. From schizophrenia, I like to call the gift of schizophrenia is that I found my voice. As Bipasha said, I'm a member of the technology subcommittee. I reached out because I knew that I had skills that could be of use and my hands needed to help others. And that's important to me. I am a part of the RACER Community Advisory Board along with Bipasha. So I really enjoy that work. And now how that work's going to be expanded, hopefully because of the new crisis center that's going to be in that neighborhood. I've written a few well-received opinion pieces in support of the crisis care levy, as well as just sharing more of our story that I'm sharing here. I have another piece that's coming out in the Seattle Times in May, which shares more about medical racism that I touched upon and the experience that we have and how critical it is that we need to understand how Black families and Black youth are underserved, undervalued, and criminalized within the current system because the system was not made for us. And through writing and advocacy, I found my passion. This is what I am intending to do with the rest of my life, being a champion for children like Jamie and others. Next slide, please. As a technologist, we often write what we call user stories, which we are writing to tell our developers how to build a system, right? So here's what I would suggest that the system needs to do in order to improve how children and youth are better or should be served or better served. Next slide, please. Help. We need to find the middle way. In the way that you all have just passed HB 1110 for middle housing or infill housing. We need the same thing here. There's a gap. There's a huge gap. There's the middle class and upper middle class, and it's really fuzzy. And we all like to say that somehow all of this works. And, you know, in the way that our president is building back better, we need to do that here. I have lost my income through taking care of my child. I like to say if my daughter had leukemia, I'd have covered dishes, I'd have GoFundMes, I'd be on the sick and shut-ins at our house of worship. People would actually care. When I tell them my daughter has early onset schizophrenia, I get blank stares and they back away from me and they ignore me. I'm completely isolated. Now, I'm a single parent, I'm a single child, I don't have siblings. My parents live on the opposite coast and are retired, so I wouldn't expect them to do anything. They're in their 80s and 90s. This is not something that they can handle. I am on my own, and to be isolated is the worst thing because it makes things worse. As I've shared, most of the social services are out of reach. When I reached out to DDA specifically to see if I could get any services for my child, I was told that basically this is a mental illness, it's not neurological, and they couldn't do anything for me. So I said to the social worker, well, I have you on the line, so do I have to lose everything in order to get help? I was told yes. And I have. What I do and what I have gained is hope and fearlessness, and pretty much I don't care. I'm just gonna push and be the pushy mom and, you know, put my elbows in people's sides in order to get what I want. And as I do that, I can help others along the way. And what we need are studies and more legislation that help kids like this. My child can't go to school because they don't know how to educate her. I understand schizophrenia is 1% of the population and early onset is a fraction of a percent, but she still needs an education, and I have to fight tooth and nail within the special education departments. And that shouldn't be. Next slide, please. So my ask of you is, what will you do? It's wonderful to be here, have your audience, be in the audience, have your ear, but ignoring this mental health gap is kicking the can down the road. As we continue to put pressure on the middle, we're going to have a domino effect of economic and housing instability. I am a case study, and I know from talking to other parents that are like me, and we're sitting in these suburbs or other places where we need help, but no one will help us. And no one understands other than, yep, we hear you, don't know what to tell you. And it's not telling a family that they have to lose everything to the point where they don't know where they could live the next month is insane. Insane. All the money that I put into the system through my tax dollars, and there's nobody to help me at all. I ask you all, what representatives or senators will commission studies to examine the depth of this problem, because it does exist. It is here. A lot of the homeless people, if though we will have more middle housing, that's going to take time to be built and set up, but more people are going to be pushed out, and these private organizations don't have a lot of money left. I've used a lot of them to get my rent paid, and they don't have a lot more to give. And I wonder who among you will write bills or co-sponsor bills for the next leg session where a lot of this stuff could be discussed. I don't anticipate something happening tomorrow, but I would ask that someone here take up that mantle and do more, because again, I'm drowning. I really am. And apparently nobody cares unless I lived on the streets. Next slide, please. Your silence is deafening. And with that, thank you for the time.
Thanks, Britt, for sharing with such vulnerability. Thanks for speaking for families having to give up their jobs and their stability to caregive their youth and kids, to share the arc of your story from your income of over $200,000 to bankruptcy. It's a story that's actually quite more common than we realize. We shouldn't need people to lose everything in order to get help. There's so much shame we impose on people who are struggling. And you are asking us to look at these financial gaps also as we look at the basic services gaps. You said to me that writing is your gift to share with the world. And I know you said politics is a way to change the world, but legislators need voices to help guide them. I see your writing and the world of politics potentially coming together, so your writing becomes a conduit for change, for the world to be a better place. I appreciate all you do to make the world a safer place for your child, but by extension, for so many other families and kids. Folks, I would highly recommend that you read her articles, especially the recent one in Seattle Times. It just left me dumbfounded. It was moving and impactful, and Nicola will share that link. So please do that. Thank you again, Britt, for being here. Appreciate it.
Great. I echo everything Bipasha said. Thank you so much for sharing your family's story with us today and for giving some clear calls to action. Much appreciated. These personal stories are, I think, a really important part of our meetings, and we're grateful to you for coming today. So with that, we're going to move into the agency Q&A. Today we have Carrie Waterland with HCA and Colleen Thompson with Department of Health to answer questions that you have from this past CRIS e-newsletter. But before we do, I know everybody's hopefully aware that legislative session has wrapped. We do plan to do a more in-depth legislative wrap-up discussion in May, but Senator Dhingra has offered to share a couple of headlines with you before we dive into the Q&A. So I'm going to turn it over to Senator Dhingra.
Good afternoon. Thank you all so much for being here. And Brittany, thank you so much for your writings and for sharing. I was going to be so excited to talk about all the great work we did, but it's truly humbling following your story and hearing about all the needs that are out there. I will say we did have a tremendous year for behavioral health in our legislature. we have spent close to $1 billion, you heard that right, with the B, on behavioral health issues, taking like the entire bucket on that. I'm going to be very quick about this because we will dig deep into this. We funded a lot of capital projects, operating budget. We had the 988 trailer bill that passed. The Crisis Relief Centers bill passed, and I'm so excited to note there will be an opening in Kirkland on a Crisis Relief Center just this week, followed hopefully by so many others. A lot of the recommendations from the Children and Youth Task Force were funded. We got funding for 211. And Brittany, after hearing from you, I just do want to add a few things that I've been involved with the Poverty Reduction Task Force for quite a few years. And we talk about exactly what you had mentioned in terms of, do we need our families to go into abject poverty before we help them? And so there's actually a lot of work we have done in increasing the amount of allowances and making sure people actually have a path to wealth generation if they're receiving services, instead of just constantly holding them at that level where they're in dire need. So lots more on that, but just know that we've been working on a lot of issues around how much resources a family can have when they get state services, and really making sure they're helped, not just put in the cycle of completely reducing all their assets in order to get help. And the one other thing I will do a shout out for is a bill on continuity of care, and Jane Beyer helped greatly with this in making sure that insurance companies cannot change your prescription mid-year or change how much they charge you for serious mental health prescriptions. So hopefully that is something that, when it goes into effect, is going to help families like you. And then we did a lot of work in actually funding special education. So that's just a preview of the work that's been done, and we will make sure to have a lot more details for our next CRIS meeting. And if there's anything in particular you want to hear about, please feel free to email and let us know, and we can do a deep dive into any of those issues. Thank you.
And Senator Dingler, I just saw a chat. Can you remind everyone what the bill number was for about continuity of care?
5100, but I'll double check.
Oh, thank you.
It's actually 5,300, Senator.
I was going to say it was 5300 It's 5300.
Yep.
You should be forgiven for not having all of the thousands of numbers straight in your head after that session. Thank you so much, Senator Dhingra. And again, if anyone has any particular items that they're hoping we can do a deeper dive into in May, please pass those along to Senator Dhingra and us, and we will look into getting that on the agenda. All right, so now let's take a little Q&A time with Carrie and Colleen. Does anyone from the CRIS committee have any questions about what was in the e-newsletter this past month? Carrie's looking very ready to take your comments or questions. Okay, I'm going
to say they're getting clear, Jamie. I think that they're getting, that's my hope, right? I don't want to speak on behalf of everybody. Could I say really quickly though, Jamie, just because we've got a short amount of time and I love to take time. I just wanted to thank Bipasha and Brittany. Thank you. That takes a ton of bravery, and yes, there's so many things that I want to say right now that I won't say, except Bipasha, Brittany, we will connect if that is something that is appropriate and meaningful and something that you would like. And that is what I will say about it. So thank you very much for honoring us with this story and figuring out what we can do to help. So that's what I will say on response to our newsletter, is any of these stories that come through, even the ones that we aren't speaking of publicly and having story time and sharing personal experiences here, pass them on to our team. We are here to help to figure out and navigate this system and make sure that things that never should have happened do not happen.
Thank you so much, Carrie. And I actually do want to mention that I received several chats from CRIS committee members after Britt shared her family story, offering to connect and help. So grateful to all of you for responding so quickly. I see a hand up from Jane.
Right, and I just want to note, I'm going to put our complaint line in the chat. So for folks who have private health insurance, we are doing a lot of work here at OIC around access to behavioral health services. And we are always willing to try to intervene when it's a health plan that we regulate. But we also take complaints for people who are enrolled in the PEB and SEB uniform medical plan as well, and work on those. So I will put it in the chat right now.
Jane, if you send that to me, I'll make sure it gets out to everyone in the meeting.
Yep.
Thank you. All right, any other questions or comments on the agency update? Okay, yeah, Carrie, I guess it does mean that those newsletters are really clear and helpful. So I'm pleased about that. And now we are going to move into presentation mode. So we're going to be hearing from Sherry Wiley with HCA about the MRSS model, which, let me remind myself what that, she will explain to you what that acronym stands for. I apologize. I did not spell it out in my notes here, but she's going to present, and here's how it's going to work now. Sherry's going to present some slides to you for 15 minutes to orient you toward that model for youth crisis response that HCA is working toward. And then Kashi Arora, one of our CRIS members who's focused on, in particular, youth and crisis response with young people, is going to share a few examples and insights from her perspective, from her professional perspective. And then finally, as I mentioned earlier, Pasha and Kristen from the Lived Experience Subcommittee are going to synthesize some of the feedback that they heard when the Lived Experience Subcommittee took up this subject at a previous meeting. So that's what we're going to do. Then we'll finish up with a little bit of time for Q&A from CRIS committee members before we take a break and then come back to have our discussion. And with that, I'm going to turn it over to Sherry, who will tell you what MRSS stands for.
Thank you, Jamie. Are you going to share the slides?
Chloe, are you going to put those up?
Oh, I thought you all were going to share those.
No, we are. Don't worry. No, Chloe's putting them up for you, I believe.
Oh, okay.
Yeah. So I didn't mean to scare you
there.
There we go.
Next slide, please. Hi, everyone. My name is Sherry Wiley, and I'm the Youth Mobile Crisis Team Administrator here at Division of Behavioral Health and Recovery at the Healthcare Authority. And my background is delivering and supervising youth crisis here in Washington State. Since we're discussing minors today, I just want to give you a content warning. We'll be discussing themes related to self-harm and suicide. I'm going to present on youth best practices in crisis services. The youth model is called Mobile Response and Stabilization Services, or MRSS. For time, I'm going to use the acronym MRSS for the remainder of the presentation. Next slide, please. Families and youth touch systems, and those systems are called system of care partners. When those partners like schools, behavioral health providers, or primary care providers notice a shift with a youth, maybe a change in behavior, increase in aggressive behavior, being withdrawn, or self-reported suicidal ideation or thoughts of self-harm, they direct parents to take the youth to the emergency department for evaluation. Once in the emergency department, families wait for hours for medical clearance before any decision is made. Some, even subacute, will go to adolescent inpatient. Many are discharged home from both the emergency department and inpatient without supports in place. This loop creates unnecessary stress and trauma for families. Next slide, please. SAMHSA's National Guidelines for Behavioral Health Crisis Care Best Practice Toolkit says someone to call, someone to respond, and somewhere to go. For youth, we don't want to pick them up and take them somewhere. We want to, for youth, the somewhere to go becomes a safe place to be. The goal is to bring the crisis continuum into the home, to respond in person when families call, and to reduce the need for restrictive facility-based care. When families pick up the phone and ask for help, we send it. Next slide, please. This slide shows the youth model on the left and the adult model on the right. They used to be very divergent. SAMHSA is aligning on the right more with the youth model because now SAMHSA is saying that for adults, there's a single point of access that's not 911. The crisis is defined by the caller, and that the response should not include law enforcement. In the MRSS model, the youth, adolescent, or the parent caregiver define the crisis, not the call taker. Teams are trained to meet the unique developmental needs of youth. They're designed to interrupt the care pathways leading to the most restrictive facility-based care, and they keep youth at home by providing stabilization in the home. Next slide, please. The goals of MRSS are to support and maintain youth in their natural environment. They sleep in their own beds. Teams work to promote safe behavior at home, in school, and in the community. MRSS improves access to care by breaking down barriers through outreach and engagement. It reduces unnecessary reliance on 911 and its assets, like police, fire, ambulance, or co-response. It decreases emergency department use and facility-based care, and assists families by linking them to ongoing natural and clinical supports through warm handoffs. I can count on less than 2 hands as a supervisor of youth crisis the times we needed to call 911 due to imminent risk or active rescue. Youth can have a plan, intent, and means, but they're often supervised or they're in a place with supervision available by an adult who can monitor them. For this reason, a response is less about speed. It's about putting an intervention in place. We want the right intervention, the right intensity at the right time. Next slide, please. There are 2 pieces to this model. There's the crisis intervention phase and the crisis stabilization phase. During the initial phase, teams respond 24/7, and they respond in pairs with a parent or youth peer, and they provide developmentally appropriate de-escalation and engagement to establish rapport. Getting a good risk assessment on a youth or adolescent with an earshot of a parent can be challenging. So this is done in person. We really want to understand what the risk is and how advanced a plan may be. Based on that risk assessment, teams are going to help parents restrict access to lethal means, including securing medications, sharps, firearms, address environmental safety needs, and create a safety plan in the family's own words. This is often the first contact families have with the behavioral health system. So teams should build a trusting relationship of mutual respect and provide individualized care that includes family voice. If there are ongoing needs after the first 72 hours or 3 days, MRSS has a separate but connected in-home stabilization phase. This is where teams meet youth in the home. There's an intensity of services, and they're going to do skill building, brief interventions, psychoeducation, and work with the family to identify natural and community supports. Natural supports provide opportunities for respite, and teams ensure connection through referrals and warm handoffs to the right level of clinical care if needed ongoing. Next slide, please. Families touch systems, and these, along with our family-led and youth-led organizations, become our system of care partners. They can identify needs early and refer to MRSS teams. These systems are stakeholders in the youth crisis system. And so teams will do outreach with these local and regional partners so they're aware of and able to make direct referrals to the youth team rather than sending them to the emergency department or juvenile justice. Nearly 3/4 of juvenile justice involved youth have a diagnosable behavioral health condition, and marginalized youth are incarcerated at higher rates than their peers. Next slide, please. MRSS is designed to interrupt the care pathways leading to more restrictive facility-based care. This slide shows the care pathway via 911, its assets, and the medical model. The middle shows the youth or caregiver and parent, and then the system partners that direct them or take them to the emergency department. Parents and youth are interconnected. So a youth in crisis impacts the caregiver's ability to respond to and and address that crisis. If a parent calls a crisis line and they don't get what looks like help, they won't trust the system and they won't call back. They're going to hang up and call 911. This results in dispatch of 911's assets. If law enforcement responds, they can take the youth either to the emergency department or juvenile justice, which can lead to family court involvement or child protective services. If EMS or co-response comes out, the youth may de-escalate, stop punching walls and go to bed, but it's not sustainable. It's not a behavioral health intervention. It's not developmentally appropriate or trauma informed. Neither is transporting them to the emergency room. 911 and its assets are valuable partners in youth crisis. And if we can train the entire system on this model, we can improve outcomes. Next slide, please. One sec. Okay, through a recovery lens, MRSS brings care to the family. In some regions, these system of care partners can call the regional or youth provider crisis line, and teams get dispatched within 2 hours. These teams break down barriers to care. They help families navigate the resources available to them in the community, and they connect them through warm handoffs. This translates to improved outcomes and can change the trajectory of a young person's life, including whether they will seek treatment in their lifetime. Investments in youth crisis services pays back in dividends because these 14-year-olds are going to be adults in 4 years. Next slide, please. This slide shows 911 on the left, the regional crisis line, and MRSS on the right, and 988 in the blue box. For youth, the transfer from 988 to 911 should be reserved for active rescue only, and if there's no appropriate supervision available to monitor the youth. 911 can transfer behavioral health calls from youth and families to 988. And we know that national suicide prevention lifelines that answer 988 are confidential, and they do a great job to resolve most calls over the phone. We want to see in-person response prioritized for minors to shift that paradigm. 988 doesn't currently dispatch teams. Regional crisis lines currently dispatch teams. So we want to consider two things. Messaging. Do we want families calling the regional crisis line for a response or 988? If they call 988 right now, do they get phone support, dispatch, or both? You know, for where I live, I can call 988 and my neighbor could call a regional crisis line and one of us would get a team dispatched. And so we want to make sure that families understand who to call, when to call, and where to call, and that they have a consistent experience and don't resort to calling 911 and don't have to tell their story over and over again to get in-person help. Next slide, please. The Healthcare Authority contracts with 10 behavioral health administrative service organizations to provide crisis services statewide. 4 regions and 5 counties had youth teams before 988 went live. These are King, Pierce, Thurston, Mason, and Clark counties. Proviso funds were sent out last year to stand up at least one youth team in each region. Those are the green smiley faces. North Sound asked for 2 youth teams, which is fabulous. Other regions are in various phases of standing up teams. There are 2 regions delivering MRSS now, and we have a SAMHSA system of care grant that's helping to implement MRSS in Pierce and Spokane counties. Next slide, please. This graphic shows how many days kids get service when they call by region. The left is the current state, and the right is future state. All regions have that blue 72-hour crisis intervention phase. On the left, you'll see those 2 regions, King and Thurston. They're providing MRSS for the full 8 weeks, and they're accomplishing this through braided Medicaid and local funding. The system of care SAMHSA grant in the orange is funding the stabilization phase in Pierce and Spokane. No, it's in blue, sorry, my apologies. The system of care grant in blue is showing the stabilization phase in Pierce and Spokane. The current state plan allows for up to 14 days of in-home stabilization, and we're working to amend that to offer services up to 8 weeks. Providers will need to contract with managed care organizations to achieve this, and we'll need to understand how commercial payers fit in. The graph on the right is the future state. This is the goal, that all youth through an equity lens have access to MRSS across the state. Next slide, please. I want to mention here that while the goal is home-based interventions, not all youth are safe at home. There does need to be some facility-based care. Less than 1 in 10 really need that level of care, and beds are limited. Washington can benefit from 23-hour walk-in facilities, which would provide opportunities for brief respite, a cooling off period. And then they can refer to youth teams on discharge. We are working to expand youth teams statewide so that all families can receive this level of service. It's allowed up to age 20. Next slide, please. Healthcare Authority is participating in a quality learning collaborative. You might have seen that in your newsletter with national MRSS leaders from other states. Our state system level partners are participating, including representatives from Children's Hospital, Behavioral Health Administrative Service organizations, Department of Children, Youth and Families, Juvenile Justice, and family and youth-led organizations. We are working with them for technical assistance in regions already doing MRSS in order to improve data collection and to inform how we want future data to flow for crisis services, including outcomes with youth. And we want all parts of the system to understand that youth and adolescents are not small adults, what MRSS is and how to access it, so that we can have robust partnerships and cross-training for all of our system partners. Thank you for the opportunity to present to you today. Next slide.
Thanks so much, Sherry. And actually, before we go to questions, I'd like to have Kashi share some of her insights, and then we'll hear from Bipasha and Kristen, and then we can do Q&A. Then we can do Q&A, because I think perhaps some of your questions or thoughts might be answered. I'm going to renege on that for just a second, because I do see Jane raising her hand. So Jane.
Thanks, Jamie. So this is very timely, and I think this would be a really good opportunity for discussions with OIC, because some of you know that legislation was passed last year that requires the health insurers that we regulate, and actually a bunch of self-funded health plans, to cover behavioral health crisis services as emergency services. And under federal and state law, emergency includes post-stabilization services. And the insurers are working through now how they implement that provision in a world of behavioral health. So I think hopefully OIC and HCA and whoever else who wants to participate, and I've been working really closely with Matt Gower on all of this. We have to figure out how this fits into a private health insurance time frame, because as Brittany indicated, not everybody's Medicaid eligible. A lot of people have private health insurance.
Thanks for making that point, Jane. It sounds like maybe that's an action item. I understand you're already working with Matt Gower at HCA, but maybe I saw Carrie nodding her head there. Maybe there's some more knitting together that you can all do based on the recent developments of legislation. So thank you for that. Let's take the slides down for just a moment and turn it over to Kashi, who has a few insights and examples to share with you. So Kashi.
Thank you. Thank you. I didn't make slides, so I'm just going to talk for a few minutes and then turn it over to others. I'm Kashi Aurora, she, her pronouns, and I work as the Mental and Behavioral Health Program Manager on the Community Health Team at Seattle Children's, and I sit in the seat on this CRIS Committee representing the Child and Youth Behavioral Health Work Group. And I'm glad Sherry went first, because she covered a lot of really great things, and I get to just echo some key considerations and share a couple examples. So In prepping for this meeting, we talked a lot about the relationship between 988 and mobile response. So I'm still very curious about understanding the pathways and what happens when youth call 988 or when caregivers call 988 about youth in crisis. So how do they get connected actually to an MRSS team is still an open question in my mind. So I'm looking forward to the discussion. And I think embedded in that consideration about pathways is questions or key considerations about how we ensure that 988 crisis call center staff are trained to be responsive to and inclusive of a diverse group of youth, including youth at a wide range of developmental levels. And so there are a number of considerations about working with and talking to youth in crisis that we'll want to be sure folks have gotten appropriate training and support to manage. The other thing that's really important about youth crisis, which Sherry mentioned, is family or caregivers may be the people calling, and they're not the person most in crisis. Emphasis on the term most in crisis, because the parent or caregiver calling about their child in crisis is experiencing some level of distress, and they may be in crisis themselves. And they're the person you're likely talking to talk about how to manage the child in crisis. And so you can imagine, hopefully, how well people in crisis process information. It's really hard to intake information. And so how do we make sure that 988 is ready to support parents and caregivers who may themselves be in crisis and not hearing information, but they're still responsible for keeping their child or youth safe? And then to echo one of Sherry's points from her slide, about getting the youth or the parent gets to define the crisis. So there doesn't have to be some objective threshold of crisis met. If they say this is a crisis and they need support, MRSS goes to support. And that really empowers the teams and systems to be more preventative, because as soon as a parent says, this feels crisis level to me, that meets the threshold for a response, which is really meaningful for kids and families. One of the things I've been thinking a lot about is how to recalibrate our understanding about how different populations will use 988. So someone shared in a previous meeting that 90-something% of calls, 92, 98, somebody knows the actual number of calls to 988 are resolved over the phone, which is incredible. And that's an adult number, right? For youth, that's not going to be the case. 70%, 80%, I'm looking at Sherry to correct me if that number is wrong, of youth callers are actually going to need MRSS or benefit from MRSS. Most of those calls would benefit from someone coming to where they are to support them and not try to resolve a crisis over the phone, especially when you can't involve the people in their life who could help keep them safe and supported. So when we build 988 for youth, or as we build 988 for youth, it needs to be with the consideration that primarily that role is to connect them to MRSS. I'm going to share just two examples because for a number of years, I did a role at Seattle Children's that answered our admissions line for the inpatient psych unit. And while that was not technically a crisis line, if you're calling the admissions to the inpatient psych unit line, you are struggling with something. And so it ended up functioning as a crisis line sometimes. And there's a couple examples I think that I want to just offer to folks so you have a picture of how valuable MRSS can be and how hard it is actually to not have that when you're answering crisis calls. My caveats, of course, is that these are de-identified and these calls were more than a few years ago. So although the landscape has changed a little bit, it hasn't really changed enough. So as I share these two, I will point this out, but I also ask you to think about what might have been different if they'd had access to robust MRSS. So a number of years ago, I got a call from someone who self-identified that she was about 16-ish, and she was in the Tacoma area. And I was on my break, actually. So I was walking to the cafeteria at Children's, and there's a notorious cell phone dead zone. And so very early in the conversation, I said, hey, I'm going to walk through a dead zone. Can I have your name and cell phone number in case we get disconnected? And she gave it to me. And as we were talking in our conversation, she disclosed suicidality, told me she was feeling suicidal, told me there weren't any adults around, and she was on a walk in the city to calm down. But that means she's out in the community, not supervised, doesn't have adults to support her. She's not in active danger, so I don't need active rescue necessarily, but there's no mobile crisis team to call. So my options are call 911, even though she's not an active rescue or at risk, or call her parents. I don't have a therapeutic resource to offer to her. So I said to her, I'm concerned about your safety based on what you've shared with me. I think it's time to involve a caregiver. And she hung up on me. And I only on a whim had asked for her name and number because I was walking through a cell phone dead zone. And what that tells me is she wants help, right? She reached out for support. She's on a walk to calm herself down. And she did not want her parents involved, which is her right in Washington state. But now I'm at a point where I'm worried about your safety and I don't have another resource. So I did have to call a well child check through 911, and I was able to find, she had a medical record at Children, so I was able to find her parents' contact information, and I notified them because I was worried about her safety. And it did take a bit of time, over an hour, but I got a call from a firefighter in the area and who told me she'd walked into a fire department and asked for some support, and that she had been safe. And I breathed the world's largest sigh of relief. And I just think about this child and this situation a lot as, if we'd had a team like Sherry described, that's who I would have called and said, you could have this group come meet you. They can go to a coffee shop, you can go to a park, where are you at? They won't call your parents until we can figure out what you need and what support is reasonable. And I didn't have access to that. And so I think she got the support that she needed, but I do wish she'd had mobile crisis and we'd had better options in our toolbox to offer to her. The second one I want to offer is a very common one, but I remember taking a specific call from a mom who called and shared that her young son under the age of 13 had been aggressive and had destroyed some property earlier in the day. And by the time she had placed the phone call, they weren't actually in crisis. He was actually taking a nap, because it turns out having that much outburst of behavior is exhausting on your tiny body. And so he was taking a nap, and she called and said, this behavior is getting worse. It's happening more frequently in our home. Her husband and her had been able to de-escalate the situation in the moment, but these episodes were getting more common and they weren't sure what to do. And so I asked some questions about what their outpatient provider situation looked like, and they didn't have any. They didn't have any behavioral health outpatient providers. So there's not a therapist who can squeeze them in sooner. And there wasn't mobile crisis. And so the options are, come to the emergency department preemptively and know that you probably don't really need an inpatient admission, but I don't really have anything else I can offer you. Or wait till he goes into crisis again and hope you can get him to the ED safely, or call 911. And those situations for families are not uncommon, right? We know something's getting worse. We don't really need inpatient hospitalization. We don't want a 911 response, but this is not working in our home and we need help. And that's where MRSS can play this really fabulous role to meet families and kids where they are. It's not uncommon to see kids in the emergency department who are at this early stage showing signs of concern, but not really fully in crisis. And we had a teenager a number of years ago come in because his parents learned his friends were cutting or self-harming to manage their emotion. And they were really concerned he was going to start, and they didn't know where else to go. You don't need to spend 10 hours in the emergency department and a ton of money on an ED visit for support with that, when MRSS could do that for you. So I'm probably preaching to the choir on the value of mobile crisis response, but I wanted to give folks a few examples of why it's so critical to have outreach that can go to families and kids where they are, and know that an over the phone call resolution is not responsive to the situation kids and families are experiencing. So mobile crisis gives us an opportunity to intervene way earlier, and building a system that supports us when youth and families call 988, they get connected to MRSS, is the dream. So I'm excited about today's conversation and how we think about making sure 988 is responsive for youth in crisis. Thank you for the time.
Kashi, thanks so much for showing those real world examples of where MRSS could have been a really powerful tool. Bipasha and Kristen have a few slides to share with you to relay what was discussed in the lived experience subcommittee when they tackled this topic. So Chloe, if you could put the slides back up and advance to the one that says lived experience subcommittee meeting themes. Perfect. So Bipasha and Kristen Wells, please.
Hello, I'm Kristen Wells. I use she, her pronouns. I identify as a person with lived experience and am a member of both the lived experience subcommittee and a smaller work group that assists with planning and facilitation. I'm here today to help bring forth some themes that consistently arise in our lived experience subcommittee meetings. Youth issues are intertwined, complex, delicate, and tender. I feel it is important to mention that we rarely have youth attend the lived experience subcommittee meetings. Mostly it's caregivers, family members, and people who are dealing with or have dealt with their own behavioral health issues as adults. Some of our members, myself included, remember their experience with mental health crises as youth, but are sharing them after having reflected upon them as adults. As adults, some of them, also myself included, have chosen to be providers or peers and are trying to help families and youth in ways they wish they had been helped in their youth. I would like to encourage the CRIS to consider meeting youth where they are to seek their input regarding the youth crisis system, as their capacity to participate in this process as it currently functions is much more limited. Next slide, please. Our current system is siloed, opaque, and very hard to navigate. Caregivers, even those with deeper knowledge of the system, have a hard time navigating it, and many have no idea where to start. That speaks to how broken our system is. Caregivers can become like case managers, keeping extensive records of events, when they would much prefer to just love and care for their youth and have professionals do the record keeping and tracking. They find themselves having to repeat lengthy histories with various providers, and it gets exhausting. Some have suggested a central repository of the records to be shared with care teams as needed. Next slide, please. Inadequate resources and gaps in the system exist. Rural areas especially don't have the resources they need. They often feel left out compared to urban hubs. They need people who understand their community, preferably people who come from the community itself. However, urban areas are also facing acute workforce shortages and seeing long waits, sometimes weeks or even months long. There is an urgent need to build up workforce while ensuring that they are well trained, properly compensated, have good secondary trauma support, and that there are adequate numbers so they do not burn out. There's an in-between space that some of our previous preventers have talked about. There are not enough stabilization resources for times when a youth is not in full-blown crisis, but at the same time not doing well. The system as it stands right now requires the youth to be in acute crisis to get help. The MRSS system tries to keep youth in the community as much as possible, which is important. However, that is not always an option. Families do at times want a place where a youth can be taken, and sometimes youth want some distance or a break from family. This calls for step-up, step-down options. For example, the 23-hour centers. Other places youth can stay for a few days or a few weeks, and sometimes even for a few months. Some of you may remember when Javi shared her story and said she needed care for 612 days before she could go back home. So there is some need for long-term care as well. Next slide, please.
So we've heard from LGBTQ plus people, people of color, especially Black and Hispanic people, persons with developmental challenges, that they don't trust the system, especially law enforcement and government. And once they've had a bad experience as a youth, it makes it so much harder for them to trust. That interferes with them being able to seek help as adults. And this can snowball into deeper crises that might be harder to treat, leading to higher instances of houselessness or increased substance use disorders. It's really important we give deeper thought on how to build trust among these communities by actively seeking them out. Something to keep in mind when we market 988 in Washington. Next slide, please.
We know that who offers help matters. Humans tend to turn to people who have similar lived experience before they turn to bigger systems. We've heard that from our LGBTQ plus people, immigrants who turn to those in their culture, and people of color especially. Keeping organizations that interact with these communities engaged and informed about resources is vital. One thing we've heard over and over is to have people with lived experience and peers be part of the process from start to finish. Caregivers would like to see their peers there, and youth are far more comfortable when there are youth peers. Siblings often feel forgotten. There are hardly any resources specifically for this group, and youth peers can be a support system for them as well. Peers play a vital role in addressing and alleviating shame, guilt, and feelings of stigma that almost all members of a family feel when there's a behavioral health crisis. Skill sets and proper training of responders also matters a lot. We've heard that first responders with CIT training do better than those who do not have that training. Next slide, please.
So there's a really delicate balance between the caregiver voice and the youth or child voice. We've been trying to have a conversation about that tender space between caregiver experiences versus that of the youth. These are situations, in some situations they align, and so it's easier to navigate, but sometimes it's not. Caregivers feel they're often not trusted by the system, they're not given crucial information, and yet feel they're responsible for the care of the youth. It feels like an impossible place for them to navigate. On the other hand, there are times when youth may want professional help, but the family is not the safe place to turn to ask for support. Legally in Washington, youth 13 and older can access care on their own. HIPAA and Washington's SSB 5889, passed in 2019, shout out to Senator Degra, who was the original sponsor, provide protections. Sherry told us that MRSS works to address this as best as they can, but youth are often on their caregivers' insurance, and privacy in that case can be complicated for them to navigate. Finally, the most complex and complicated situation is when the caregiver believes that the youth needs help, but the youth may not agree. Is it that the youth is not able to recognize they need help? Is it that the parent or caregiver's belief is inaccurate? Who decides? We heard from parents how the system failed them and their family when their youth died by suicide. Anosognosia and assisted outpatient treatment are themes that come up often in this context. But there are also parents who realize that due to complex reasons, they were not able to understand their child's journey. It was important for the parent to meet the child where the child was, and the parent was glad to have the resources that helped them become more supportive parents, which then vastly improved the parent-child relationship. Peers play a huge role in helping families come together by facilitating conversations between various family and community members. We really can't emphasize enough the role of peers in this system. Thank you for allowing us to bring forth some of the repeated themes from the Lived Experience Subcommittee.
Kristen and Vipasha, thanks so much for preparing that synthesis of what we heard from the Lived Experience Subcommittee. It's, I think, really nice to reflect back those voices before we move into our discussion. That really helps inform our discussion. Chloe, do you mind taking the slides down, and we have about 9 minutes to this is more Q&A, taking any clarifying questions that CRIS committee members may have for Sherry, Kashi, Kristen, or Vipasha. And then if I'm sure you have feedback or comments or things you want to discuss, we'll save that for the discussion after we come back from break. Anna.
So first of all, I really appreciate y'all acknowledging young people who may not have parents or a family that's a support system or maybe the cause of their trauma. So thank you for acknowledging that. My question is though, when a young person calls 988, will they be taken at their word that they're not comfortable having their parents involved? Or is there going to be any risk of them of check-in with the parents? I'm just kind of wondering, you know, can young people be assured that if they call and they ask their parents not be involved, that will be the case?
Sherry, is that one you can field?
I can speak from the provider line level or the regional crisis line, but not from 988. I'd have to defer to the NSPLs.
Oh, of course, yeah. And let me see if Michelle or Jan or Levi have any insights there.
Yeah, I can answer that, Jamie. I think, you know, generally we talk to a lot of youth and they remain anonymous. You know, we might not get any information on age or anything like that. We would just know that they're a youth, and if they're not willing to share information and have their parents involved, the only way that parents might become involved is if it was an active rescue or emergency intervention situation where we had to initiate that process through 911, and then parents, you know, would become involved secondary to that emergency response.
Thank you so much for jumping in there, Levi. And I also see a note in the chat here from Betsy that, and I recall that I've heard this as well, that each 988 call center has a different standard. So that actually, Anna, is a great topic to raise for our discussion when we come back, some of the complexities and considerations associated with serving young people, and reflecting on Kashi's example of getting a young person's contact information and then relaying that. So let's make a note to put that at the top of our discussion when we come back at 4:10. Dylan.
Yeah, thank you for bringing up the part around the, who gets involved at when. I'm wondering, is the goal to establish a standard practice when it comes for what that risk tolerance is? Because I'm just speaking from an agency level, everyone has a slightly different comfort with that. You might go to one supervisor and say, yes, we need to call 911 or activate their emergency contact. And where others might have a little bit more of a tolerance to that. And into my experience, schools have been pretty, like school councils had a really low tolerance for that. And so they're calling it. So I'm wondering what are we trying to get to when it comes to involving parents or other adult supports?
Well, I can speak about from the regional level, not the 988 level, but so, adolescents in the state of Washington, age 13 and up, have a right to seek and receive behavioral health and substance use treatment without consent of the parent or caregiver. So when MRSS teams go out and the youth doesn't want the parent involved and they're at the age of consent, which is 13 and up, then the team will meet that youth wherever they agree that they want to meet, rather than going to the home and not maintaining their confidentiality and seeking treatment. Sometimes it's not safe for for their parents to know they're even seeking or receiving services. So schools are very critical partners in this space. So I can go to the ED at 3 a.m. and open a kid that's been sitting there for 18 hours. And if I get a release of information for the school, and if the parent, if they don't want their parent to even know they're being seen, then we can go to the school and meet the youth there and provide that intervention in place there. So where it becomes, at the point when you decide to bring a caregiver in, is when you have a safety risk. So you have limits of confidentiality. The youth is aware of what those are, including mandatory reporting requirements, and you communicate that consistently throughout the intervention. So if there's a safety issue, absolutely, you can bring the parent in. An example is you have a kid with a plan and intent, and they don't have means, but maybe they know the code to the gun safe. I can call that parent. That's a limit of my confidentiality. So does that help explain it?
Sort of. I'm just having the fact that there's just, I think each provider's sort of tolerance for that can vary quite greatly. And yeah, I've worked with young people who really just they really like double and triple checked to see where like I'm at or like how much they can share. So and so that might be, I'm just imagining that might be a potential barrier for folks who are they're seeking help, but they might hold back certain levels of information with the potential risk that other people that they don't want to get involved get looped in.
Dylan and Sherry and other folks who've been sending me chats, I think this is probably going to be a really important consideration and complexity for us to tackle today. Because I saw a lot of nodding heads. I do have a couple comments in the chat from CRIS committee members indicating this has come up in the lived experience discussions, for example. So I'm going to suggest that we put this at the top of our discussion when we come back, because we're definitely, that's really exactly what we wanted to segue to as we talk about considerations related to youth crisis response. Kashi, do you have a clarifying question or something to add to this?
I have
stick with clarifying questions here.
In addition to that topic that I think would be helpful to discuss, I recognize and don't want to detract from the conversation that needs to happen around how youth access crisis care confidentially in ways that is their right in this state. And I'm the part of my brain that knows our emergency department is seeing 10-year-olds for suicidality is wondering if they're under 13, how do we know that when they call 988, and how do we be sure that their parents are getting connected to that because they don't have the same rights and their parents really should be? So I'd love for us to talk about both of those, but not in a way that detracts from the other. I know that many youth are in situations where caregivers don't provide that support. So thanks.
I made a note of that to queue up when we talk next. Oh, Michelle McDaniel just sent me a note here. I'll pass it on to all of you. There are clear RCWs that all regional crisis lines in 988 need to follow. Put that in the chat to everyone. Okay, any other clarifying questions or before we take a short break? Sherry, Kashi, Kristen, Bipasha, thank you so much for preparing all of that great information that clearly is already informing our discussion even before we've started it. So really appreciate the time you took. We're going to take a short break. We are going to come back on camera at 4:10. So if everyone can, all CRIS committee members, get the stretching you need and come back with your cameras on at 4:10. We'll dive into our discussion. See you soon. And Chloe, if you could put that break slide up, that way if anyone jumps on while we're on break, they know what's up. Okay, folks are starting to come back on. Give everyone a couple of seconds here to get back on the camera and we'll get started. Okay. So where we left off was starting the conversation about some of the considerations around youth crisis response in relation to this MRSS model that Sherry presented from HCA and some of the other feedback that you heard from the Lived Experience Subcommittee and from Kashi's observations and professional experiences. And I actually I have a couple of questions to frame up this discussion, but as I promised you, I think we can start with the issue of confidentiality, both for young people ages 13 and up, and also as Kashi raised, particularly since we can't ask how old people are, young people are, there may be instances where we're hearing from children who are under 13. So let's, Chloe, if you can you queue up the discussion questions, slide 42, please? Thank you. So these are the broad questions that I want to ask you today or frame up our discussion based on what you've heard about the MRSS model, the Lived Experience Subcommittee feedback, and your own personal and or professional experiences. How can we better ensure that youth calls to 988 result in the outcomes we aspire to? In other words, that engagement that was laid out for you, the engagement that Kashi talked about being really, really valuable in some of the circumstances she's encountered. Along those lines, what are the current barriers to these outcomes, and what are some ideas for how we can address these barriers? So I think we'll post those questions, those broad questions in the chat and take down the slides so that I can see all of your faces. But let's get started with that first point around confidentiality for young people, and parallel to that, some of the different ways in which 988 lines handle this. I think Dylan might have mentioned that there's also variability in comfort level of the individuals who are actually making this decision to make a call. So I have a couple of comments in the chat I want to mention. I heard from Puck. I appreciate Dylan's comment and had been discussing some of that in the lived experience conversation. Dylan's comment referring back to what Dylan was talking about ensuring confidentiality. We've been discussing some of that in the lived experience conversation with Sherry and Matt. There's a question of how we inform youth of confidential resources without the parents' rights movement activating around it. So that's a comment from Puck. Let's see, I already mentioned about the RCWs, and Levi has a few things to add that will be helpful. So I'll call on Levi briefly. Let's see if there's anything else in here. Okay. Levi, do you want to get it kicked off?
Sure, thanks, Jamie. And I think this is a really good conversation, a really important conversation. And I just want to make sure that we bring chat and text into the conversation as well, because those particular modalities are more highly utilized by youth. And so I just heard last week from SAMHSA that right now across the entire 988 network that 80% of individuals contacting chat or text services through 988 across the country are under the age of 25. And 82% of those are coming into the chat with current suicide ideation or suicide ideation within the last 24 hours. So, and we recognize that there's generally that higher acuity. I can say one thing that's a little bit different from 988 chat and text than it is from phones is there is a pre-chat and text survey that is voluntary, but often we get that information, and that will let us know the age of the individual contacting us. It doesn't give us any identifiable information, but it can give us certain information that help know the age and better position our intervention, as far as information. I would add, as far as Dylan's comment on, definitely we try to mitigate circumstances where when our counselors are working with youth, they're quicker to maybe go to emergency intervention or things like that, that they really take a measured approach and a similar approach in assessing safety and risk. And, I would also add that counselors receive training on things like non-suicidal self-injury and, navigating different, different pieces of working particularly with youth, callers, texters, or chatters. So, it's timely in this discussion because we just received feedback from chat text interaction from a parent who was involved in a situation where their child was communicating with us, and it did end up in an emergency intervention, and they were upset that we didn't have the ability to contact them prior to law enforcement basically arriving at the home, which, again, getting back to we'd much rather have an intervention by MMRS teams or some other type of mobile responder, but this was in the case of national backup for chat and text, and not all areas have those types of resources available. But the parent was rightfully so, they were upset because they were like, why couldn't you contact me before contacting law enforcement? And the reality of that situation is we had no way to contact them. If the child doesn't share their information or a contact phone number or anything like that, our only means of intervention is working through 911 and local law enforcement to initiate intervention that way in emergency situations. So just wanted to add kind of some additional information as we start through this conversation, and just recognize that we're looking at a lot of different factors, and trying to operate in the most positive and supportive way we can for youth, but then also operating with kind of quite a few barriers in place as well, and things that we have to navigate. So
I see a couple of hands up, but before I take those, Levi, a question for you through the chat. Can that chatter or texter get connected directly with MRSS? I believe that is related to the chatter or texter who was concerned about not being notified before law enforcement was involved.
So there currently is no mechanism to directly connect them to MMRS. So in the context of chat and text, it's those modalities are completely separate and on a separate system than 988 phones. And for us at VOA, we operate coverage for the state, but then also national backup for the entire country, and for that chat and text infrastructure. So it also depends on which location that's at. But if it's in Washington State and we can determine location and contacts, then we would work through the regional crisis line or RCL partners, or our direct relationships with providers to try to initiate contact or get those resources.
Jan, can I pick on you? Do you have a similar or different experience with your call centers?
I think it really is about that ability to connect with the callers and ask questions that would help us to try to identify what is the age of the caller, finding out where they go to school or what kind of activities they might be involved in, that help us to maybe get a better sense of their age. If we have none of that information, then we're just going to resort to how do we provide the best triaging and intervention so that we can be sure that that individual is safe. And of course, if they would provide us with any natural supports that we could include in the conversation so that we can get them that assistance that they need, then that's what we're going to try to aim for. You know, if someone is hesitant to provide us with information, then all we can do is be the best sleuth possible and try to somehow ascertain through various questions what their age might be, who else is in the home with them, but really to try to determine the level of risk and see what resources we can bring to bear.
Understood. Thanks for jumping in there, Jan. I think Dylan raised this question, and I just want to bring it back to the forefront about whether or not it would be desirable to have, is that the objective here, to create some standards across and Dylan, please correct me if I'm misrepresenting the question, but I understood it as broader than 988 respondents. It's also across anyone that's going to have that initial contact or be that initial step in the pathway, like what Sherry showed in her graphic, for a young person in crisis. Did I capture that right?
Yes, and I do think, and I do know there's laws pertaining to this, but there's also that interpretation of it, and so that variability, even within the same agency, someone might talk to one provider, and they might set off for that emergency response, where another provider might maybe take a beat and just take a moment to figure out other solutions that might be more amenable for the young person.
Thanks for raising that question, Dylan. Ron, what do you think?
And I apologize, my bandwidth is not available. So I just want to highlight, I think the vast majority of times it will be probably the goal to not have law enforcement respond in these situations, but there are those times that we have to, and I would just hate to have us so excluded from consideration that we don't have access to training. Someone highlighted earlier that if we have trauma-informed training or specifically youth-informed training, we can do a better job. So, before we just have a goal of no law enforcement response, just keep that in mind. I hope that there will be times that we do respond because the other resources aren't available. So if we have the ability to acquire specific training to taper our response and tactics, we can probably minimize the traumatic impact that we've caused in the past.
Thanks for sharing that, Chief Harding, and reflecting, I think, on a point that on the slide that Bipasha spoke to about how a lot of, Bipasha, correct me if I'm mischaracterizing this, but I recall you said that in the lived experience subcommittee, you're hearing from young people, particularly people of color, people with developmental challenges or differences, and LGBTQ plus individual, or people who identify as LGBTQ plus, that they have experienced early such interactions with law enforcement or government that have made them mistrustful and make it harder for them to be comfortable accessing support.
Yes, that is what we keep hearing. First, I want to acknowledge Chief Harding. Thank you for acknowledging that there has been some hurt caused in the past. I think just acknowledging that is a big step towards building trust and building bridges across these communities. I think we just need to speak truth and see how we can repair. That's how we can move forward. I do want to say one thing. As a person who's worked on the crisis line for 25 years, I've been answering calls from people. There are laws, but all the lawyers here, laws are up for interpretation. And how they interpret it by an agency, how an individual supervisor interprets it. And I agree with Dylan. It is very, it depends on the situation. And each situation needs to be met where it depends on the caller and stuff like that. I know that I, as person who responds to calls, will always try to meet my caller where they're at. I cannot force them to give me information because it's a very tricky situation because that makes it more unsafe for them. So I agree with what Jan said. We do our best to keep the dialogue such that it is safe, that they then voluntarily will give that information. That would be the ideal situation. I would like to emphasize that it would be nice to have some clearer guidelines on what the rules are around youth, and provide training to 988 staff on how to go about that when youth call or even parents call. So that's all I have to add for right now. Thanks.
Thanks, Bipasha. I see a couple hands up from Claudia and Anna. Before I call on them, I just want to synthesize a couple of things I'm hearing here. One is I'm hearing that there are laws, but there are still interpretation that happens in how those laws are applied. And I see a comment here from Dylan to clarify, it isn't just police response, but also mistrust of varied interpretations of what makes something a crisis by a clinical provider. So I also heard earlier that there were that there were questions about whether or how it's being communicated to a young person, what their confidentiality rights are. So that's another piece that's come up. And then I do want to just highlight a comment that Puck shared with me, uncomfortable with framing youth's rights as barriers. So we are discussing, I think, this tension that particularly folks that are on the front end are experiencing, of how you meet the needs of a young person. And when sometimes you might want to be able to share who they are with someone else, but that those are their rights, and there are good reasons for those existing. So that's a tension we're navigating here. Claudia and then Anna.
Thank you. Just don't want to pretend they represent all communities of color, because that's not what I'm trying to do. I think they will caution us when we said, you know, minorities feels this way, because it's really not the case. Many communities of color are wanting police intervention, want to get the support of the police department. Other ones, they don't. It depends on your personal experience. But what I wanted to try to convey is the voice of the families. I get so many outreach of families who come from communities of color, especially new immigrants. I would say new immigrants, no people who had been here for many years. This is new immigrants who are trying to battle the system, and they have kids who got in crisis. And the first thing they receive when they call is, depending on the age of the kid, is we cannot tell you anything. And families who are new immigrants cannot understand what that means, because they don't understand the laws. They don't understand that you are 13 and older. We cannot share that information. So how do we make a system that respond to the needs of the kids, but at the same time is really welcoming and supportive to families who wants to be part of the life of those kids? I just got last week, I have 2 cases of people from far away who were calling me, and he said, my own clinic, Claudia, please, we need to get information. We know this has happened with my kid, and how we create a system that is supportive and welcoming without breaking the law. But that we always ready to receive the families, to explain, to convey, you know, how the system works. And sometimes in times of crisis, we don't have a space for that. And that's my worry, right? Because we're so much focused on the college and the youth and what's happening, that we totally close the doors for our families who wants to be involved in the life of the kids. So that's my piece.
Claudia, you raised a really important, you raised a broad point about families and being and centering around families as much as youth, but you raised a really important point in particular about the experience of immigrant and newcomer families. So it sounds like the system feels very culturally incompatible with their values. Am I hearing that right? I know that's a massive generalization on my part, but
that really, yeah, that is definite, because that's what we are in our culture. We're responsible for the kids. Our kids will stay with us until they're 30 years old. So it's a whole, this is something that we don't understand. How come I cannot be part of the, you know, my kid is in crisis, how can I get more information? So how do we explain that in a moments of crisis?
Okay, so you're asking the question to how can we create a system that both respects that right of young people for confidentiality and acknowledges that this may feel very frightening and uncomfortable and unfamiliar to families, particularly immigrant and newcomer families? Okay, that's a great question. Anna and then Levi.
Well, expanding on that, I think, one thing we need to consider is it's a very nuanced situation because, we do have kids that want confidentiality, and in a lot of cases where it's the family causing the trauma, the families can also claim they want to be involved, but that's because they want to be involved in their kids not being gay, or and so I think that's going to be the difficult part, is separating that. In other cases, you'll have a child that's calling that doesn't want their parents involved simply because trust has been broken for some reason between the parent, but it's still a good situation to call the parents. So I think that's going to be where it gets complicated, and where we have to kind of figure out where to draw the line and how to have that balance of confidentiality, just like you had already mentioned. And so, but I did have a couple questions. First, maybe it was already answered, but I don't remember Dylan's question being answered about whether or not we're working towards standardization of responses across the state. So it's not just dependent on who picks up the phone when somebody calls 988, or dependent on the region. Is there going to be a state standard beyond what we already have in law? And two, I went to a youth panel this last summer. I believe Kashi had, you were emceeing it, I think. It was with Pramila Jayapal, and there were youth there that were volunteers for the teen suicide hotline. And I'm just kind of wondering, has that gone away, or has there been integration between the teen youth hotline, the teen suicide hotline, and 988, so young people can still get a young person to talk to if that's what they want? So those are my questions.
Thanks, Anna. And before we dive into those, I do want to circle back to what Chief Harding said earlier. I focused on one piece of Chief Harding's comment, but Adam reminded me that there was a bigger point there that Bipasha spoke to, which is that while we can maybe generally agree that law enforcement should not be involved in most of these situations, the reality is that at some points they might be. And if we exclude them from training, then we don't have the opportunity to help minimize the potential harm or mistrust that can arise from that. So thank you for calling that out, Adam, that was an important part of the point that needs to be reinforced. Let's see, I have Levi and then Kashi, and then I'm going to go to the chat, but I do want to echo what Anna just said, which is I think the question's still out there, both whether or not there's already an expectation that we're moving towards statewide standards for response, and if not, is that something desirable based on our perspectives? Okay, Levi and then Kashi.
Yeah, so I want to thank everyone. This is really great conversation and needed conversation. A lot of really great comments. I think I agree. We want more training across the board, whether that's for our counselors or for law enforcement when they're responding. I think it's important to emphasize, and Bipasha mentioned this, Jan touched on this, and really right now our counselors they're meeting people where they're at. It's a case-by-case basis, and they're very familiar with the fact that sometimes family is driving the crisis that's going on for that youth, and we want to be very very aware and working with them and navigating around that. And we hear really bad outcomes too, sometimes where parents' response if an emergency intervention takes place is that they're angry at the child. They're angry because law enforcement showed up in front of their house, or they're angry because their child didn't tell them before they reached out to some other service. And so I think those are things that are always in the front of our counselors' minds as well, and things that we're trying to work through and navigate, because the last thing we want to do is create additional trauma through any intervention or trying to help a youth when they're really struggling. I think to Dylan's question, I don't know of any standardized practice that's being talked about right now or anything that's in the works. I think that's kind of the importance of this conversation and the conversations that have been happening on the lived experience subcommittee is because we do need to think really critically about this and how we want to approach things moving forward. So
Levi, for clarity, so it sounds like, if I'm hearing correctly, having some of that flexibility to understand the situation, but also be able to kind of follow one's professional training and expertise in making some of these judgment calls is really important. In your mind, does that mean that standards might be counterproductive in your experience, or?
Yeah, it's going to be really tough to work through that, and because there does need to be space to kind of clinically evaluate and work with that person on where they're at that time. So I think there needs to be ability to work around those things. If we're talking to a youth, whether it be phone, text, or chat, and they're describing it would be a really bad situation, or they are showing really strong feelings towards having their family know about anything, then we can work around how can we bring other resources and support in. It was mentioned before, how can you work with schools or other partners so that you might be able to provide intervention outside of kind of the family, the family network, if that's contributing to the crisis or creating worry or hesitance to engage in getting help.
Understood. Thanks for sharing those direct experiences. I'm going to take Kashi, and then I have a few comments and questions in the chat. Kashi?
I am coming up with more questions than answers about there's still an outstanding question in my brain about what happens if how does a youth get identified when they contact 988, right? That chat or that texter has a voluntary survey that Levi mentioned. Is that standard across the state? I don't know totally, but that's voluntary still, right? So you might be chatting or texting with a 12-year-old and safety planning with them and their parents don't know. You might be chatting or texting with a 16-year-old and they may not want their parents to know, and that's their right and they get to maintain that. And then my question also is, once we identify that it's a youth, the best practice would be to connect them to MRSS so that it's not just a one-time intervention from 988, but it's an actual connection to this ongoing mobile stabilization. It's not clear to me how that happens. And if 988 transfers them to an RCL, do they make a handoff for you, or does the youth have to tell their story again? And so I think the conversation about confidentiality and the pathways of connection to care are getting conflated in a way that I would ask to re-separate them, that youth have rights in the state to opt into their mental health care without their parents knowing, and that's a good thing. Right? They should have the ability to seek care, especially for all the reasons that we have outlined. And it's still very important to me that if you are a 988 staffer or a team, that you actually know you're talking to a youth so you can connect them to the best practice resource that exists. And that's not about their confidentiality or their rights to privacy. It's about making sure that they get connected to the resources in this state that we have funded and built for them, that we know actually work and provide the best practice. So I think I'm asking more questions than I'm answering, but I would love to learn more about the pathways of connection to care and disentangle that conversation from the rights you gain in your mental health treatment, because that should not impact your access to mobile response. It should impact when 988 tells your family, or if they have to call 911, but those are different conversations than how do you get the mobile response that you need.
Thank you, Kashi. I think you're taking us back to our original question, which was just to remind everybody how we got from that call to 988 to the outcome that I think we desire, which is this young person accessing MRSS, this MRSS model. And I hear you saying this isn't necessarily about when we contact their family or if we contact their family, but rather how we understand that the MRSS model is the one we should be connecting them to rather than the adult system. Did I hear that right? Okay. And then you raised another question. I don't know if anyone has the answer to this and they can put it in the chat about whether or not that initial questionnaire that I think Levi mentioned when you do the text, if that's a standard that's happening across the state or if that's unique to Levi's system. I'm going to pause for a moment while everyone mulls the bigger question about how we go from that call to 988 to the outcome we're desiring. And I'm going to go into the chat because we have quite a bit of activity in here. Bear with me, I'm just going to make this a bigger screen so I can see it. All right, so Bipasha is reflecting back on Anna's comment about how there are all kinds of complexities around whether or not it's desirable to involve the family. She says, thanks, Anna, for speaking to the complication of when and where to involve family and when not. It's a situation by situation and needs deeper knowledge. And then adds standardization and training for that is imperative. Dylan asks a question, are teen peer volunteers also covered as mandated reporters? I'm not sure on the law around that, if not the peers, but the adult supervisor is. Does anyone know, if anyone knows the answer to that, if you don't mind putting that in the chat, I will relay that back. I hear from Adam, there are oftentimes in rural areas where law enforcement is all that's available, and we need to make sure that law enforcement is on the team and not the enemy. Claudia asks a question, can a parent who does not speak English, are they able to use that text system on their native language? So again, if someone knows the answer to that, please do throw that in the chat. I'm going to share a link to a webinar about FERPA and HIPAA that Dylan shared. And then Anna is reflecting back on a question. Wonder if my question can be answered regarding the teen suicide hotline, who is comprised of youth volunteers. Did that service get dissolved? Or is there a way to tie it into the 988 system? You know what, there are a lot of big sort of once-off questions here that I'm wondering if it might be useful to summarize those and then do some kind of follow-up, because my chat is full of a lot of really good questions and we may not have everyone on the call today who can actually answer all of those. Carrie, do you have some thoughts here?
You know, I'm wondering if the person is talking about Teen Link potentially. Is that what,
was that what you're
talking about? Okay,
yeah,
wonderful. Well, we can do a little bit of talking about Teen Link, but I also know I was looking for, where's my crisis connections friends? Bipasha has her hand raised. I'm going to stop talking.
Jump in here, Bipasha.
Yeah, do you know wait. Did I mute myself? I did. It's interesting you bring that up because we were having a conversation in our lived experience work group about like when a teen calls the 988 lines, can they be like amongst the 3 hubs, can there be a subspecialty for youth within the hubs that the hubs share basically? Is that an option to then say to the youth, you know, we will transfer you over to that particular, where they have much more deeper knowledge on working with youth and the system as it responds to the youth. So we were just wondering if that could be, you know, ideally if someday 988 had the option of, if you are a minor, press whatever number, that would be ideal, but we know that's going to take some time. So in the meanwhile, can Washington do something in terms of like, I'm a youth, I am calling, I want to speak to someone who works closely with youth and knows the youth system and can explain that to me. So that's something we did talk about, interestingly.
Thanks for jumping in there, Bipasha. One more comment here from Puck. Everyone calling 988 should have the opportunity for informed consent around their participation, the possible mandated reporting outcomes. So I think this is going back to the question that Kashi asked about whether or not this was a standard practice to do this initial questionnaire in the text. Bipasha.
Sorry, I got to answer that. Kashi, I can only speak to be on the phone because I don't do text or chat. I used to do chat a while back, but not anymore. But it's really odd when someone's in crisis to start with, hi, what's your age, or where, it's a little awkward to do that. So we try to weave it into the conversation so it's a more natural flow. And I will have a lot of people say, why do you want to know? I don't want to tell. And some people will just say, I'm so-and-so years old. When people are young, their voice broadly, if I might make a very broad generalization, sounds young, though there are lots of adults whose voices also sound young. I do ask when it's relevant to the call, would you mind sharing your age with me? And sometimes when they ask why, I do try to explain. I say to them, if you are below this age, if you're between 13 and 17, I would tell you something different. If you're below 12, if you are a minor, I could maybe look up resources that support minors. But I am very reliant on them saying it to me. And this is that very sensitive area in crisis. Do you capture someone's information right off the bat? Or do you have that sort of, and that is a skill set that you will bring to the table as a person who's answering the phone. And that training, it's possible to train people to develop that skill set and finesse it more on how do you engage a caller so they feel, I've been cussed out by people, but eventually they say thank you, some of them, because you take the time to meet them where they are at. So it's possible to do with proper training. And I do want to say, when I'm there, I have my supervisor supporting me in real time. And that makes a huge difference in how I handle my call, so that I don't feel like I'm there alone flailing around or even just sorting out through my emotions, because I'm not a robot, I'm a human being answering the call. So having someone there with me, process the call with me, really does help. And I will say one more thing. Whenever I've said, almost 98% of times I tell a caller, can you hold, please? I'm going to ask my supervisor if what we can do to provide you. I have almost never heard someone say no. If anything, I hear a sense of relief in their voice, because there's that feeling that, oh, this is not just some one person somewhere sitting in a room trying to solve my crisis. There's a system there that this person is trying to engage, So I think it matters sometimes to callers to know that there's a system trying to come through for them, and not just one lonely person sitting somewhere trying to solve the problem. But it's a very delicate issue of trying to figure that interaction out. Sorry, this is my area of work. I'm deeply passionate about this.
Well, that's why you're here. So we're grateful for you speaking up. Back to that initial question about how we get from that call to 988 to the outcome we desire. If I'm taking what I'm hearing, it sounds like in places where this model is available, certainly the folks on this call, their personal experiences are that the people responding to that 988 call have the tools and the skills and the training to, in most cases, know when to refer that young child or connect that young child with MRSS. Kashi raised a question that I'm going to ask of those of you that have experience. What does that handoff look like? Like, how is that happening now in places where this model, these teams are available? Does anyone have an answer to that one? Levi.
Go ahead, Vipasha, if you want to go.
I can only speak to a little bit of King County, which is, for example, I do not speak for the agency I volunteer at. I just want to be very clear. I'm speaking about my experience as a phone volunteer. But for example, if it's an appropriate referral to make to CORS, which is available in King County, for example, we have to fill the screening form in. So at that point, when we explain the service, most people realize, oh, there's a service available. And at that time, they're more amenable to sharing the information because they have opted in to use that service. They say, yes, I want that service. And we explain to them, well, then we need this information. So I think that, but the handoff is, as of right now, to the best of my knowledge, and I'm speaking only for the handoff, let's say to CORS, it's not a warm handoff. We do the screening, it goes to CORS, and then CORS makes contact with the family or the youth, if that's what the case is. So I think also how the handoffs are done varies depending on area, region, agency, service. It's not standardized. And I think that's what I was like, we need to talk some measure while we honor differences in regions and specific calls. There needs to be some coalition of some standardization that everyone is trained to follow.
Kashi, you want to jump in and then Levi?
I bet Levi is going to answer the same question. So Levi, did you want to go first?
Go ahead, Kashi.
Okay, sorry. I think what I'm curious about is I'm leaning toward an ask of the CRIS committee that we consider a press this number if the person in crisis you're calling about is under 18 or 17 or under, because to Bipasha's point, identifying standards that help us if we identify a youth caller and how we make that connection. If is actually pulling a heavy load in that sentence, if we identify a youth caller, and that is dependent on agency standards, training, experience. And Bipasha, to your point, these are your human beings answering these phone calls. I've taken some of them, not nearly as many as others. And I myself, when I am stressed or nervous about a youth or a person in crisis, I'm not thinking at my best. And I know that you all get fabulous training and support to manage that. And that's what a 988 call center does for their staff. But the if is pulling a heavy load there, that like, if we were able to find out that this is a youth, we could potentially have some standards to put in place to connect them to MRSS. And I think I would just ask this group to consider if we would make a recommendation that there is a number you can press or something where there's an opt-in to a system that supports to a youth specific. You know, the caller is a youth when you pick up. I am completely empathetic to, it's incredibly off-putting to start with. Hi, my name is Kashi. Can I ask you 3 questions before I ask you how you're doing and why you're calling me? But we know if it's a youth, there's going to be more things we want to consider. Every region is supposed to have a mobile response team by the end of fiscal 22, which we're coming up on, right? And so there should be a resource available. There should be different considerations, and we shouldn't be at the mercy of an if we can identify them. Sorry, Levi, thanks for letting me go first.
No apology needed. So I think, yeah, I think that's what we can define and work towards. But, you know, the reality of the situation, and, you know, Bipasha, you know, touched on this. Right now, the resources are different from county to county and region to region. And yes, those teams are, you know, starting to come online, but there's a lot of teams that aren't fully functional, or they're still recruiting staff. And so, you know, we have to work through that piece. And you know, to answer your questions about that 988 to teen connection, it's not always direct. It can result in going from, you know, one person to another person. So there can be a redundancy in, you know, in storytelling and information. Of course, we try to limit that as much as possible, but that's kind of the reality of the systems right now, is that does exist, and that is a piece of it. We try to mitigate all of those you know, redundancies or inefficiencies that might create you know, additional trauma or just hardship in navigating the system, but they're there.
Levi, I just want to make sure I'm understanding. So it sounds like you're speaking of the realities now, but the intent or the aspiration would be to smooth out some of those redundancies or points where someone has to tell the story a couple of times. Am I hearing that right?
Yeah, definitely. And I think that's a goal across the whole, you know, the whole system is taking a look at work between 988s and the RCLs, and how, you know, how we can eliminate some of those pieces and make things more efficient and work better. You know, some of that will be dependent on technology pieces and some of the things that are being worked on there. And you know, other portions of that will be a continued conversation and partnership with everyone involved.
So there are a few comments in the chat regarding, and I do need to clarify if this is regarding the specific suggestion of having a separate youth line, or rather something that just clarifies that we're talking to a young person. I think those might be two different two different suggestions here. And I think Kashi, if I was hearing you right, you were more just having some function that would clue in the line that it was a young person. It wasn't necessarily going to be an entirely separate youth line.
I think that's a good clarifying question. I don't know that I had made a suggestion on one or the other. I think the CRIS committee should advise on that.
Okay. Yeah, and I wanted to make sure we kind of separated those two pieces because there's a couple of comments in here. One is from Colleen Thompson, who's representing Department of Health today. She asked that we flag this discussion and have DOH come back with some more clarifications because the issue of creating more specialized lines did come up during session. There may be some challenges with what Vibrant would endorse, and we don't want to be giving out misinformation at this point. So maybe we have DOH circle back with, Colleen doesn't want to give out any misinformation at this point. So she'd like us to circle back with DOH on that one. And then let's see, Vibrant does not allow screening. So again, we probably need to speak with more expertise about that. So we'll flag that as a follow-up.
Thank you, Jamie. I can jump in
Oh,
too.
please.
This did come up during the legislative session around the agricultural line and screening and referral to that. And we did hear some, I think, some concerns and challenges from Vibrant about what was feasible with what they would allow and also with what resources are available. And so I can't speak to it in detail with expertise, but I just want to highlight that did come up and we had to suggest amendments around that specialized line for agriculture. And so I just want to flag this for a larger discussion with our program subject matter experts.
Thanks, Colleen. We'll make a note in our action items and next steps for that. I hear from Michael reading, the challenge of a separate number for youth is that mobile response teams for youth are dispatched through the crisis line and intended to be dispatched through 988. So it would not be a good service to one in crisis to transfer back and forth in order to achieve the ideal end state of connecting with MRSS. So I think, again, we're talking maybe about two pieces. One is a way of understanding who we're talking to. And the other is this question of, I think this came up with the question about the peer teen, can't remember the name of it, but I know my children at their high school have it. Couple more comments in the chat. I want to clarify that law, and this is from Sherry Wiley with HCA, who presented to us today, sharing that law enforcement are partners. They contact kids in the community and we want them to refer directly to a reliable youth team rather than transporting them to the emergency room or juvenile justice. So in regions with MRSS, law enforcement calls the youth team all the time. So thanks for sharing that. Let's see. Teen Link, thank you, Kashi. Vipasha, both of you reminded me. All right, so I want to pause for a moment and just talk about where we are in this discussion, because I definitely feel like we still may be at the top of the funnel where there are a lot of ideas out on the table and we're starting to narrow in. I think some of the things we talked about today are, again, how we potentially how we create more tools to support people who are answering those 988 calls, making that connection to MRSS. We talked a little bit about the realities of where these teams stand today and their ability to, in our ability to do that warm handoff from the 988 call to MRSS, and where we aspire to be. Let's see. Oh, we have some insights here from a community member who's on the call today. CCS, Crisis Connection Services, is that right? Is that acronym? Have the youth mobile
Catholic Community Services, Jamie.
Catholic Community Services, thank you, Betsy. We have the youth mobile crisis teams and stabilization teams in Pierce, Thurston, and Clark counties. So many of the questions about what to do when require clinical decision-making as well as clarity and training. And based on their experience, the experience of this person, we have clear RCWs about confidentiality and family involvement beyond the statute and our internal protocols, and our staff and supervisors use their best clinical judgment. So I think this echoes what Levi was sharing. Adding that often we can work with youth 13 and up to determine whether and how to involve parents. Often once a youth feels calmer, they decide they would like help talking with their parents. It's not hard and fast, it's a conversation. So thank you. This is from Mary Stone with Catholic Community Services for sharing her own experiences on that and for giving me the opportunity to relay that to you. We have just a time check here. We have about 15 more minutes for this conversation. And like I said, I think we're still kind of at the top of the funnel. And this feels like maybe we still have a lot of wrestling to do. I'm going to call on Mark, and then Betsy, I'm going to queue you up because I'd like to hear from you what your thoughts are on maybe where we might want to aim the CRIS discussions next to be really supportive of future deliberations that the steering committee might have. Mark?
Thanks,
Dr.
Jamie.
Snowden, sorry.
Yeah, my question has to do with what's the reasonable expectation of what happens with MRSS if you're calling from an emergency department? Because as the chief of psychiatry at Harborview, I think it's a really unfortunate situation anytime we get a youth in the emergency department for a psychiatric problem. I know our team calls CORS. I know my colleague over at Children's is also having a significant issue. And so I'm just, it sounds like it works really, really well if you call from the community, but I'm not sure what really to expect to happen if you're calling from the emergency department with a youth.
Dr. Stone, to clarify, do you mean if you're making that call to an MRSS team or to a 988 line? Okay.
Correct. Because we wouldn't be calling 988. We would be directly calling.
Directly calling, okay. Does anyone have the answer to Dr. Snowden's question there? Or is that one we should flag for our list?
I can speak about that, how it works in regions with the teams. So usually our system partners like the ED or the emergency room and adolescent inpatient, it's such juvenile justice, schools, they all call that youth provider line directly, or the regional crisis line directly to have a youth team respond to the emergency room. So that's a big question in my mind. How will those system partners access youth crisis services with 988?
Thanks, Sherry. So I'm making a list of questions here because I think Kashi put it well. There may be more questions than answers at this point. I'm making a list of questions that we've raised here, including how that process happens, how it's going to happen for EDs and other system partners to have that warm handoff to MRSS, or how that should work. I think the question still is in the air about what level, if any, standards or guidelines we want to have across the system to support people in making the connection between the call to 988 and MRSS. But I think what I'm looking for in our last few minutes together in this conversation is something that could segue us to some next steps for how, what should we focus in on the next time we talk about youth crisis response, so that we can get to a point where we're making some, we're sending some ideas for recommendations to our steering committee to act on. And I'm gonna pick on my thought partner here, Betsy, to see if you have any thoughts about where we might take this next based on what you've heard today.
Thanks, Jamie. So as I'm listening, fascinating conversation. I really appreciate all the discussion. I am separating in my mind the conversation about confidentiality and whether we want to have recommend standards. And it's on that front, it sounds to me that we have RCWs and regulations that each responder is adhering to, and that standards perhaps are, across the board too restrictive. We want to leave clinical judgment in the hands of those clinicians and those call takers to really be able to respond in the moment with the person on the line. So if we set that aside and understand that we do have the foundation of laws and that, you know, there's interpretation there, but we do all have guidelines and standards in that way. Then I'm thinking about, I see that Matt Gower is on the line today. I'm thinking about dispatch protocols and the work that HCA is doing and forming a work group to get some feedback about dispatch protocols. I don't think I've seen MRSS in the dispatch protocols particularly. And I'm wondering if we would want to investigate whether dispatch protocols, and maybe it's not dispatch, but it's really, you know, protocols related to connecting to an MRSS team, both with our 988 call centers as well as the RCLs, which I think are, you know, I know are more developed in terms of their connectivity with the with MRSS teams, whether that's a place to go to investigate, to see whether we can have some standard protocols related to how to engage, when to engage the MRSS teams. Matt, do you want to correct me if I'm wrong? Can you speak to that at all? And, you know, have you been doing some work, and Sherry, have you been doing some work already on this front? And, you know, maybe we bring that back to this group.
Yeah, as part of our entire best practice toolkit that we're putting together, mentions a lot of caveats for youth around youth confidentiality, working with youth, being developmentally appropriate. And then in the dispatch protocols, it does have several call outs for youth, especially around that fact of once you know it's a youth, to just contact the MRSS team or mobile crisis in general to do that dispatch. But I completely agree with you that that's definitely an area that we can improve. And, you know, the access to MRSS, I'm stumbling for a word here right now, but you know, to your point, you know, there's a lot of legal interpretation, and so, you know, we can't give legal advice as an executive agency, but we are putting in there, you know, practices of, you know, building relationships, making common the, you know, ROIs, data share agreements, business associate agreements. That's what I was trying to think of, that type of thing. And this is stuff that we'll be implementing across the crisis system as we start building it and rebuilding it, with the designated 988 crisis contact hubs going into effect. So yeah, but that is, you're absolutely right. This is an area that we can definitely kind of push policy without having to push legislation or rules or anything like that.
Yeah, so Jamie, I think that there's a natural place to follow up, to do some digging in, and it's great timing that we have the dispatch protocols work group coming up in May. And we do have youth representatives on the children and youth representatives on the work group. And I think coming back to this group with some more conversation about what those protocols look like and what some recommendations or some feedback might be by the CRIS. So, and if you all remember, the work groups that we've established are intended to do some digging in, do some more work, and then bring back the work of the work group for feedback from the CRIS. So I think that's a nice natural next step. And we can also talk more about the work that Colleen was mentioning from DOH. So just thinking about next steps.
And I flagged a couple of other pieces that came up that I think might be worth just us considering for follow-up. One is around communication. Specifically, I think we heard folks raise the question of how we communicate with teens about their rights and what the mandated reporter situation might be for them, so they can make informed decisions and have informed consent. I think we talked about communication with emergency departments and other community partners about what the steps are to connect folks with MRSS. And then Claudia raised the question of communication with families, in particular ones that may not be very familiar with our system, or for whom there may be a real cultural disconnect from where they come from and the way our system works. And then the other piece that I flagged for follow-up might be training for law enforcement and other community partners who may be that first step in this process for young people. So those were some other themes that came up, I think, in this conversation. Do you want to highlight comment from Puck in the chat? I think that when talking about youth, it's important to remember and consider family fear of child protective services engagement in addition to law enforcement. So that's an important, I see a number of you nodding your heads there. In our last 5 minutes on this discussion, are there any other themes that you heard today that you think warrant some follow-up conversation for us at a future CRIS meeting or in maybe a subset discussion? I know we covered a lot of ground here today. Outreach and education. Thanks, Puck. So around some of those things that we talked about with respect to communication, but maybe also knowing that these systems exist and there are supports in the community for people. Am I hearing that right? Yeah. Thanks, Puck. And then from Bipasha, variation on coverage based on insurance. Thank you. Any others? All right, everyone. Well, I really appreciate both the very engaged discussion today and so many of you contributing your professional experiences, what you've been seeing out there, what you've been experiencing out there. And then, oh, Marie offered one, answers to the questions about discussion of the protections for youth calling 988. Yeah, we have actually a long list. I'm saving my chat here. We have a long list of questions, I think, including that one that we are going to flag for some follow-up. So we'll be getting back to you with those. All right, well, then let's move to some action items and next steps. I took down that we have a number, as I said, a number of questions, both in the chat and in our discussion that we are going to circle back with you on. Colleen raised that in particular, some of the questions around a dedicated youth line or even that initial press this button if the person in crisis is under between the ages, I guess, of 13 and 18. I can't remember how we framed it, but we're going to hear back from DOH on some of maybe the legal or other considerations around that particular question. I understand that Jane and the Office of the Insurance Commissioner and HCA are going to continue to connect around coordinating some of the outcomes from this session with respect to MRSS and coverage, especially when it comes to private payers. A number of you asked me to pass your contact information along to Britt so you can adhere to her call to action. And so I'm going to make those connections and then leave it to her to follow up with you. Nicola, did I miss any action items?
I think you've got it, Jamie, just the additional work with the dispatch protocols.
Yes.
And the continued conversation there. So
excellent. Before we move into public comment, I also just want to give one final thanks to everyone who presented today. Really appreciate all of the great content that you put out there, and I think it really informed a robust discussion today. So appreciate all. I have been seeing all the iterations of the presentations and slides over the last month, so I can assure you, as you probably saw, that our presenters put a lot of work into bringing this material to the CRIS today, and I'm very, very grateful for that. And as ever, very grateful, especially to our lived experience subcommittee and all of the folks with lived experience both on the CRIS and in the community who are participating and informing these conversations. And now I think it's time to move into our public comment. I have two people signed up for a public comment today. Karen Kelly, followed by Laura Van Tosh. And we're going to, I have 2 minutes for Karen. Laura, we'll just see how it goes for you. We still have a little bit of time, so we can start with 2 minutes. And if you wind up needing 3, that's fine. So what I'm going to ask is when I start the clock for you, Karen, if you could just come on camera, introduce yourself, and we will start the clock here.
Thank you. Can you hear me okay?
Yes, I can.
Okay, yeah, my bandwidth isn't going to allow my camera on.
Oh, that's no problem.
Thank you for the time. Excellent presentations today. I wish I could be more involved with the Lived Experience Committee, but I'm in a chemotherapy for cancer journey, so my capacity is limited. But I want to ask the committee to such relevant conversation, needed conversation, and truth about the rights of youth 13 and above to access treatment. And I don't want to move away from that. I am passionate about that. They need that right for their safety, and I acknowledge that. And I'm asking the committee to look at the other side of that coin, because my experience with my daughter, she was not well enough in her journey to really follow through with help. And so she utilized that age of consent to decline. And she chose to live homeless. We wanted her in our home. We actually created a unique individual space for her with support of CPS in our detached garage, so she could have a safe space. And she chose to be on the streets. And she would go into the ER after being abused or being high and afraid that she was gonna, pass out. And we wouldn't find out until we got the bill. She would give our name, she would give our insurance information, our address, and then she would go about her way. And I just really want to encourage the committee to discuss potential training when a young person needs that extra support, to really inquire about those natural supports, because we wanted to be engaged and we wanted to participate in however her help she wanted to get looked. And I just don't want families like mine to be forgotten. And I guess my time's up, so please consider that side of the coin.
Thank you so much, Karen. And as a reminder, our CRIS committee members are listening, but they won't be responding to the comments. But I appreciate you sharing them. Also, if you have a written version that you'd like to send to us, I'll put the email address in the chat. Next up is Laura Van Tosh. And Laura, when you're ready, go ahead.
Good afternoon, and thank you for hearing my comment. I hope that it can be, if it's not commented on today, that it can be towards the top of your agenda the next time you meet. And that is that I'm looking at the HCA CRIS website, information for CRIS, and there are reports next to each of the meeting dates. So for today, April 26th, there's hyperlinked reports that are being referred to for the meeting and just at large. And I'm looking at the behavioral health impact report for youth, the behavioral health forecast summary, and behavioral health report, access to behavioral health report. And I guess what I really want to point out is the need for people now on the CRIS committee. This is a little hard to explain, but while you're meeting for many, many hours now about the 988 system, the 988 system is actually rolling forward. I know I called when it was just very early on in the process, and somebody did answer the phone because the number was in effect federally. And so the program has been operating since July and in Washington State. And I think that it's really important that the committee or some subset actually find a way to crosswalk what's actually happening in reality to what's happening now as you're talking about future issues such as DOH coming in and circling around some of the things that were discussed today, et cetera, that while you're talking about these issues, the issues are actually happening. And I'm not real clear what that means when a youth calls and some of the issues that were brought up today. I was gone for maybe half an hour in the meeting because I had an appointment, but I came back and it just seemed, I wondered if people who were youth calling 988 while you were actually in this meeting today during the hours of 2:30 and 5:30, whether or not the system is still functioning when everybody's basically sitting in this implementation meeting. And in terms of looking at the reports that I just mentioned that are next to the meeting date on the website, there's a long run-on, very neat and tidy listing of all the public comments. And I guess I would love to see some coding of that data. Is there crosswalking of the public comments into the quote hard comments that you're actually making decisions around in the meeting? Our comments even refer to, I think coding is the only word I could come up with, which is a way for you to summarize the comments so the comments are actually embedded in your decision making in some way, so that there's an ability to actually cite the research that's been generated by many humans over the course of these many months. I hope that's clear. It's a little hard to explain. That's why I felt I needed an extra minute. I hope you understand what I'm saying, and if not, please ask me. Thank you.
Thank you, Laura. Appreciate it. All right, I think that concludes. I don't have any other signups for public comment today. So I think that concludes our meeting for today. We'll give you a few minutes back in your evening. Again, thank you to everyone for your participation, CRIS committee members for your participation in the discussion today. Thank you to everyone who presented content, and most especially thank you to our community members and CRIS committee members and lived experience subcommittee members. We're so grateful for you sharing your stories and your personal experiences. We'll see you next time, next month. Take care, everybody.